Hello, welcome. The purpose of this segment this morning is to talk about Orange County's new selective spinal immobilization protocol. It applies to all the people working here in Orange County, whether you be volunteer or career, and you can find it in the Medical SOG section 4.12. For a long time, things have changed in this business and things are rapidly changing. They're very dynamic. And there's a great change and a push to evidence-based medicine. This guideline is no different than any other evidence-based medicine protocol or guideline. It's based on some studies that were done a long time ago, 10, 12, 13 years ago. And there were two studies called the Nexus study and the Canadian C-Spine study. And they can be found anywhere on the web. I very much encourage you all to go and look them up. But there were studies where people thought a lot of people are coming to the hospitals fully immobilized and end up having very minor injuries, and there was no real need for them to be immobilized. So they thought, how can we possibly come up with a way of figuring out whether all this immobilization is needed or not? And their criteria was, if I wouldn't consider him as a physician in the hospital when he arrives or she arrives, doing x-rays, then all that preparation in the backboarding probably wasn't of any great benefit to the patient. So they studied thousands and thousands of patients in both these studies, and they found that this criteria that we're going to discuss later on was quite predictive, very predictive, of whether or not those patients were going to end up needing to have x-rays and potentially having a spinal cord injury. So having got all that data together, they then thought, well, why can't we extend this out to the EMS field? Because if we find there was no purpose in doing it, that's fine in the ER, but if it's not going to benefit the patient, surely we shouldn't be doing it anyway. Therefore, the EMS folks should not be doing it. So they did some more studies to see if EMS providers were as predictive in their exam and the results as accurate as they were in the hospital. And the interesting thing about a lot of these studies is it found that EMS providers who actually performed the exam the way we're going to discuss it here were more predictive than the hospital-based providers. So as I say, this is not new science. We haven't discovered a parallel universe. It just hasn't been used in this area very much. But the science has been out there and it's absolutely evidence-based. The exam will be predictive and these patients will be better off because of it. For a long, long time, we've always been taught mechanism of injury is predictive of injury. And we really know in the evidence base that that's just not supported at all. Now, we're not saying the mechanism of injury has no part and plays no part. What we are saying is it's part of a toolbox. It's no longer the all-guiding thing. We examine the patient and we see if the symptoms and signs we see are predictive of this person having an injury. So for many years we've had protocols more than guidelines, and A always followed B, which always follows C, and there was very little clinical thought in this. And as we go forward, we really have to consider the differential diagnosis, and that requires us as providers to understand differential diagnosis, to understand the mechanisms of these injuries and be able to make decisions based on a clinical thought process. There are some very simple criteria for this exam, and we'll go through them now. First of all, what this exam and this guideline is not, we need to say. This is not a guideline that says we don't backboard patients. Backboarding and C-collars are out the window. That's absolutely not the case. What this is saying is that a selective group of patients will not benefit from backboarding, may actually have a detrimental effect on them, and therefore, because we have no reason to believe that it'll benefit them, we shouldn't be doing it to them. Any treatment, medications, or anything we do to a patient has to reasonably be expected to help them. So the days of dogma, you do this because you were told or somebody taught you or it's traditionally been the way it's done in your department. As an industry, we're changing to evidence-based medicine. So there are some things with this guideline that you need to know about. There are some absolute exclusions. In other words, things that are present in your history and physical that this patient cannot be fitted into this guideline. They're excluded right off the bat. And those are patients that are not awaken oriented. They can't converse with you. They have a GCS that's less than 15 and they're less than 8 years old. When you see them first and they present and you examine them, if they have any paresthesia, which numbness and tingling, they're excluded from this guideline right off the bat. They're intoxicated. Intoxication to the point to where you do not feel that the information they give you, the questions, the answers to the questions back and forth in the physical exam and history taking, would not be reliable. You wouldn't trust them. Again, altered levels of consciousness, which really is repetitive here, if they're intoxicated or they're not awaken oriented. Now, emotional distress is another thing. Some patients we've all seen, they may not be substantially injured, but they're so upset and distressed by what's happened to them that you cannot get a decent history and physical from them. So, if you cannot get the patient to concentrate on you, or if they're not concentrating, you can't redirect them back to your questions. Similar to the intoxicated person, you have doubts that the story they're giving you is true, then you're going to have to exclude them or consider excluding them from this guideline. Now, distracting injuries is another thing. It's pretty much the same as the emotional distress, but a patient who has a fractured femur, a very, very painful injury, and they're concentrated on that pain, and you cannot bring them back or redirect them to you to where you're trusting what they're telling you, you're probably going to have to exclude them too. But again, these are clinical judgments. You've got to make decisions here. People who have known vertebral disease, these are patients that you would probably say are in a relative exclusion criteria. The others, the previous ones, would be absolutes. If they have known vertebral disease, they've already had surgery on their C-spine. And if you'll note, we're talking about C-spine here. We're not in this mentioning T and L spine because immobilization is based on taking care of the C-spine. These patients you'll have to consider and think. You'll still do the exam on them, but they're certainly ones that should give you a much higher index of suspicion. Again, like I said, previous surgeries to their neck. If they have delayed pain, most all significant injuries have pain immediately. Now, what do I mean by a significant injury? And this is a thing that people will have some problems wrapping their head around. We're not necessarily overly concerned that they have a bone injury to their neck. We're interested in whether that bone injury is impinging that space in which the cord lies. That's a significant event and has obviously enormous potential for bad things to happen to them. But if that exists, patients will have immediate symptoms, paresthesia, numbness, and of course in a complete cord separation, they'll be completely paralyzed. So delayed neck pain. I'm in a car accident, I'm up and walking around, now my neck hurts. Those patients you perform the exam we'll talk about on, and if they rule out, so to speak, they have no need to be immobilized. Patients who are up and ambulatory at the scene, by being up and being ambulatory, they have pretty much ruled themselves out of having a significant C-spine cord injury. And that's something that you and I have all seen, patients that were out of a car, self-extricated, and they still end up being immobilized. There's no evidence to say that that is any good whatsoever or will have any benefit to them whatsoever. Patients that are 65 years old and above, we know that they're a special select group. Their general bone health is lesser than younger people, and they're inclined to, frankly, break easier. Those patients you have to, again, have a high index of suspicion with. It doesn't mean they must be immobilized. It means you watch them more carefully and you perform the exam that we're going to talk about. Once the exam is negative and they're cleared, they're fine. So what is the exam? Very simply, very simple exam. The thing about it is it must be done correctly, the same way every single time you do this. So what do? We approach the patient, we get a history from them. They're not in one of the exclusion criteria. They're not underweight, they're not intoxicated, they're fully awake and oriented. You go on from there. You ask them, do they have any numbness and tingling? Very simple. If they report having paresthesias, numbness and tingling, that excludes them from the guideline. You can't use this guideline with them. But if they do not, there's a second stage of the exam. You palpate their C-spine. Now, by palpate their C-spine, I don't mean touch their neck and see if they have pain. You physically put your fingers on the bones of their neck and work your way down. If that doesn't elicit any of the rule-out criteria, paresthesia, numbness or tingling, or pain, that part of the test is passed. You ask the patient to rotate his head, or her head, 45 degrees left and right. Now, 45 degrees, if you look at a clock, is on the right side between 5 and 10, and then between 50 and 55 on the other side of the clock. So it's this. It's not this. Anybody you ask to look out over their shoulder any given day of the week is going to have some stiffness and tenderness in that. So please be careful that you do the exam 45 degrees. So they have all three things. They have no palpated cervical spine pain. They have good range of motion. They can move 45 degrees left and right, doesn't produce any pain, numbness, paresthesia. That patient does not need to be immobilized. That's it. And as I've said earlier on, and as we all know, that's quite a change from what we normally did. So it really, you will have patients, probably 6 out of every 10 of the patients that you would normally have immobilized will not be immobilized. You'll perform an exam on these people. So that's what's very important. In order to be immobilized, so to speak, you have to fail the exam. So no longer do we do the process of immobilization just to be sure. We do it because we are sure that there's a problem, because we've done the exam. Now, there's always some outliers in every guideline. And as I said before, you have to consider your differential diagnosis, and you also have to use good clinical thought process in this. Like I say, always outliers. The 65-year-old is one of the ones that will often have an injury that you wouldn't suspect. But once you do the exam, and the exam is okay, they're fine. They don't need to be immobilized. People who fall from 3 feet, 5 stairs, those are ones that you have a higher index of suspicion. Doesn't mean you immobilize them just because they fell. It means you do the exam. If the exam dictates what your next action will be. If they don't have any problems with the exam, they don't need to be immobilized. Axial loading injuries, people who dive into a swimming pool and land on their head, or maybe people playing football where they knock helmet to helmet. Axial loading injuries. They are people that you obviously have a high index of suspicion for having an injury. You perform the exam. If the exam is negative, they don't need to be immobilized. People in high-speed crashes. Now, the criteria is 62 miles an hour, and the reason it's 62 miles an hour is you've got to remember these were Canadian studies originally, and that's just a conversion from kilometers into miles an hour. And how will you know it was 62 miles an hour? Well, you really won't. Again, if it looks like a high-speed road crash, the same as you would always think is high-speed road crash, then it is. You don't have to be exactly specific, but the criteria is 62 miles an hour. So they're going at highway speed. They're not in a town going along slowly, or they're not rear-ended with low speeds. This is clearly highway speed crashes. People who roll their car over or are ejected from their car. Now, previously, those people, a lot of people would immobilize them purely on the mechanism of injury alone. If they're awake and oriented, they're not intoxicated, they don't have the distracting injury, they don't have paralysis or paresthesia when you get to them to start off with, you would perform the exam. If the exam is negative, they don't need to be immobilized. ATVs are another thing. ATVs, we know historically and in the evidence base, they tend to produce proportionately more injuries. Again, high index of suspicion, he was on an ATV or she was on an ATV, performed the exam, then you're fine if the exam is negative. Now, what we need to make everybody understand and be aware of here is we're talking specifically about the need to immobilize. That is backboard, C-collar. We're not talking that the patient has no injury. This is specifically guided towards protection of their C-spine. They well may be seriously injured, but this is the guideline specifically and solely to do with their spinal immobilization. So please do not presume that because they, for want of a better word, pass this test, that you do not do your complete exam that's appropriate for whatever their presenting injury was. So just a quick review of what we've done. For everybody in Orange County here, it's in our medical SOGs 4.12. There are some absolute exclusions. You must be awake and oriented. You must have a GCS of 15, in other words. You are 8 years or older. You're not intoxicated. You don't have paresthesia or numbness or tingling. And there's not so much emotional distress that you can't get a good, reliable history and physical from the patient, either because of, like I said, their emotional distress, or they have such a terrible distracting injury that they're distracted by the pain and you can't get them onto the actual, to concentrate on the questions. Relative contraindications, things you need to look at a little bit more closer. People with known vertebral disease, people that have had previous surgery on their C-spine, delayed neck pain. I didn't hurt at the time of the injury, but I do now. They're ambulatory at the scene. From whatever the event they had, regardless what it is, they're up, walking around, doing normal things. People who are 65 or over, those are your relative exclusions. Then you do the exam. The exam is very simple. You ask them, do they have any paresthesia? If they don't, you palpate the cervical spine itself, not either side. If they don't produce any of the symptoms that we would not want to see, paresthesia, numbness, tingling, then you ask them to rotate their head 45 degrees left and right. If that does not produce any of those symptoms, your patient doesn't need to be immobilized. So that's the guideline. That's the guideline that we're using here in Orange County. And if you're a member, as I say, whether it be a career member or a volunteer member, that is what's expected of you. In order to be released to use this, you have to have watched this video, and there needs to be written documentation that you've done that. It's something that's a little different. It's evidence-based. It is predictive. It's safe. These patients will do better because of it. There's a sufficient body of evidence to say that prolonged immobilization, for many, many, many different reasons, can be and is harmful. It's injurious to the patient for many different things. Older people have problems with pressure sores that later develop to ulcers. They have sepsis. So it's just to say that they're not better off because of this is underplaying. There are patients who will have bad outcomes and actually die because of an extended period of time on the backboard. The other thing is we increase pain. Once you get tied down, you're going to become sore and stiff. So your actual pain from your injury is increased by being on the backboard. So if you don't need that backboard for your health, you're better off without it. And also that pain, in a lot of the studies they remark, that pain needs more medicine. So we have to give them more, basically chemicals. They need more narcotic medicine. If you don't have to give anybody any medicine, you're better off, obviously. So that was the complete review of this. I hope it's been clear. Please review the studies. Like I say, it's the Canadian C-spine study and the Nexus C-spine study. They're out there on the web, as is an awful lot of information. Well, that about wraps up the summary of the guideline. I hope you've enjoyed it. Hope you've learned something from it. For those of you who are in Orange County, it's in our medical guidelines 4.12, as I said before. This video and all the other videos we have are available on our Facebook page, which is County of Orange Fire and EMS. It's also available on YouTube if you search COFEMSvideos. COFEMS videos, all one word. And I'd also encourage you to visit our partner site, clinicalbraintraining.com and fire-emsbraintraining.com. Thank you. Goodbye.